Flaherty, and thanks, Allie. Great job keeping us all on the straight and narrow here tonight. We're going to talk about lower back pain and talk about some things that you guys can start doing tonight if you'd like to get working on lower back pain if you've had it for a while. So here's our agenda for tonight. We're going to first talk a little bit about some statistics with low back pain. We'll get into the anatomy of lower back pain. In our office, we talk a ton about posture, and we do a lot of work on breathing, so we'll get into that next. We do a lot of work with stretching and strengthening. We'll talk briefly about that. And then we'll get into some chronic pain, some fitness ideas, and then we'll just really we'll finish up talking about physical therapy and if it's a good fit for you or not. It's not a good fit for everyone, but we like to think it's a good fit for most of us. And then we'll finally talk about, are you ready to kind of handle your lower back pain if you've had it for a while? I always say why, and it's a guy I used to work with, physical therapist, and he would always say, how's that working out for you? And so I always say I'd rather see people try to get some treatment and get some things to do versus just trying to think that they have to live with back pain. So my goals for everybody for tonight is, number one, that you become a little bit more educated about lower back pain. Two, that you don't feel like you have to live with severe back pain. I don't think you have to live with severe back pain, and I want to hopefully express that to you guys. I do think getting some help from a medical professional is really important, and there are definitely plenty of practitioners out there that do great work. We have some good relationships with some local physicians, chiropractors, massage therapists. I actually, my wife, for those of you her, owns an acupuncture clinic that's right behind my office. So the nice thing is we have a lot of different practitioners that we can work with that help us treat patients. And then again, my last goal is that you'll take home at least 3 exercises to give you guys some things to do tonight. So low back pain, is one of the leading causes of disability worldwide. This quote is from 2010, but it's still the case. Americans spend $50 billion a year in back pain. That to me is an insane number, but it is what it is. Interestingly enough, most cases of back pain, they're mechanical in nature, which means it's not things like fractures or cancer or infection. It's actually usually more something related to the joint or something related to muscles. This is my favorite study when it comes to lower back pain, and probably, 80% of the people that come into our office with back pain, almost none of them have had an MRI. And this is one of the main reasons why. This is a study that was done in 1994. And you might think, well, geez, 1994, that was a long time ago. But it was a classic study. And basically, to summarize, they took about 100 people, 98, and they put them in an MRI tube. Now, every one of the people that were being tested were asymptomatic. They had 0 lower back pain. From the scale from 0 to 10, 0 is, nothing, 10 is severe. They all said 0 pain. About half of them came out of the MRI tube and had something wrong with one of their discs. We'll talk about what that is in a minute. And then there's varying levels of how poorly that disc was, from something that was just kind of bulging to something that was larger, like a protrusion. So, and then 38% of those people had more than 1 level. So here's people that had no pain at all, but yet they also had some dysfunction with their spine. So a lot of times if you go to see your doctor with back pain, one of the last things they're probably going to do is to do an MRI. And honestly, I think it's a good reason. We'll talk about that in a little bit. So let's just start off talking about the anatomy of the back. And obviously today we're going to focus on the lower segments, the lumbar vertebrae, the sacral vertebrae. As you can see, those are towards the bottom. But you also have a cervical and a thoracic, and those that, thoracic areas in the middle of your back, those all attach to the ribs. And obviously the cervical is where your neck is and helps to control some movement and rotation in the neck. Nowadays, screening for scoliosis has been significantly better than it ever was. And so we're seeing less and less of this, but we still definitely see it, although what we're seeing now is not scoliosis that someone was born with, but we're seeing it more related to postural changes, weakness issues that have created these these mechanical changes in the spine that cause that lateral curve that you see on the right spine. So this would be us looking from the back at someone, and you can see the top is their skull, the back of their skull, and then the bottom is where their pelvis is. And so a scoliosis would be a lateral curve. So I want to get into next, just talking about some common conditions that we see in the clinic. The first one is the fancy term for arthritis, and they call it spondylosis. So spondylosis is a very, very common problem, generally seen in people over the age of 50, more common in women than in men. Common complaints are a lot of stiffness, a lot of stiffness in the back, stiffness in the hips. Very, very common that this person that has this is also very sedentary too as well. So if you look at the picture on the left side of the screen, you're going to see some varying levels of what the disc looks like. So what we're looking at is we have the vertebrae stacked up on top of each other, which is that kind of brownish color, and in between each vertebrae is the disc. So at the top level, we see what a normal disc might look like, and then as we go down, we see varying levels of what maybe a degenerative disc might look like, a bulging disc might look like. You can see it looks like a little bit of like a small circle towards the back. A herniated disc is more of a larger part of the disc that protrudes out into the space. You can have a thinning disc, and then the lower segment is what we see a lot of times with these spondylosis people, is they have a lot of degeneration. So you can see the bone doesn't quite look as normal down the bottom as it does on the top, and that's what happens with aging. It also happens just with a lot of overactivity. So I want to show you an exercise, very simple, easy exercise that you can all do at home. And so I'm going to try and just see if I can get back to, let's see if I can make this work. Allie, can you see the person doing the exercise?
I cannot.
You can't, okay. Here we go. How about now?
I can.
Great, awesome. So here's, I'm going to play a little video. We use a program called MedBridge in our clinic, which is where we get all of our exercises from. And just so you all know, what we're going to do is sometime either today or tomorrow, tomorrow or on Monday, we're going to email everyone a PDF of the presentation as well as these 3 exercises. So don't worry about taking too many notes. I'm going to send everything to you guys by email. So I'm going to play the video. Hopefully you can hear.
Kevin, you can't hear the video very well.
Okay. All right, I'll turn my volume up. So we'll try that with the next video we're going to show. So basically everyone can just see very basic single knee to chest. Now you can see he's laying on the floor. So generally my plan for most people that I'm a little concerned about them getting down and back up off the floor safely, I ask them to do this in the bed. So if you haven't, you're going to feel like you're going to struggle getting down on the floor, don't get on the floor, just get right on your bed, and you can easily do this same exercise. Another thing to think about is you can see that he's pulling his left knee to his chest, but the right one is straight. So if that puts too much stress on your back, you can always just bend that opposite knee, and that will take a little bit of pressure off the back. So something to think about there. All right, so let's go back to our presentation. So that first one is our single knee to chest. And again, I'll send you all a picture of that. Another area in the anatomy that's really important for us and we treat a lot is the facet joints. And the facet joints are where we see two vertebrae stacked up on top of each other. So you can see the picture on the right is the picture from the side, and they've taken two of the vertebrae out and they can stack them on top of each other. And what I see, what you may or may not see, is there's two areas where there's our joint on either side, and those joints move back and forth. They're the facet joints. They allow us to turn and bend and rotate and have smooth movement in the spine. So sometimes those can get stuck. And a lot of our treatment with spondylosis is to try and not only work on improving movement of the muscles, but we're also working on trying to improve the joint mobility as well. So what do we do with these patients? So basically, we spend a lot of time talking about posture. We do a lot of work on pain management, and we'll talk about that a little bit later in the presentation. We're constantly working on trying to improve the spine move. We want the spine to move better. And then we also want the muscles around the spine to move better and to be strong. And so we do a ton of work with the core, as well as just try to get people out doing some activities like walking. One of the first things I will talk to almost every low back patient about is I want them to start walking. And, walking is a simple and easy thing to do. It costs nothing other than your time and effort. And so for me, it's a great way to kind of get yourself started with some general exercise, is just getting out and walking. Now, we always have to preface it and say, I don't want you walking 5 miles if you haven't walked, a half of a mile in a long time. So you've got to start low. You start with about a quarter to a half of a mile to start with, and over time that can build up. But consistency with walking is a really fantastic way to keep ourselves kind of loose and moving. The picture on the right is actually an MRI exam of the lower spine. And what I included this so you can kind of see how those lower segments, if you see there's a white line right in the middle, and that's your spinal cord. And then you can see down the lower section where the black areas are kind of wedging into that white line. And that's where we get some compression on the spinal cord, and sometimes spondylosis issues can cause some symptoms either into the hip or down into the leg. And that, when it gets bad, it compresses that way, and that will cause some increase in discomfort. So another big area of treatment for us is sciatica. And, for patients that have some sciatic complaints, they're generally over the age of 35. They usually have lower back pain. They may also have some leg pain and or tingling and numbness. It's usually generally specific, so they'll come and they say the back of my leg is sore, or my foot is numb, or my big toe is numb. And then they have a lot of difficulty with sleeping. They also generally have some poor postures. They have a lot of work where they're sitting, and we do a lot of work with them. Now, the two pictures on the left, one on the left shows you the sciatic nerve, and you can see that yellow kind of spaghetti-like thing that's going down the back of the leg is the sciatic nerve. It actually comes from 5 different levels in your spine, and then connects through the buttock, and then goes down the back of the leg and splits behind the knee and goes down into the calf. And the picture on the right just shows how there's a lot of musculature that's around that nerve. So one of the jobs for us when we have someone with sciatic symptoms, we're trying to say, okay, is this coming from the nerve being compressed somewhere, or is this more of a muscle problem that's causing some of that compression? Either way, the second exercise is a really great exercise to start trying to loosening up the hip. And so I'm going to try and go back to my exercise program again. And we'll pull up that next exercise. I'll turn up the volume. Hopefully y'all can. So again, you can see she's laying on her back. She has her left hand pulling her right knee towards her left shoulder. Good. All right. So you can see that she's kind of bringing that knee up towards the chest, but over to the opposite side. And that's a nice one for just kind of helping to loosen up the hip area dramatically. So we do a lot of work to that piriformis. You can see the picture over here on the right side of the screen shows the piriformis. So, you know, the hip muscles are generally very small, but that's one of the bigger ones of the hip joint. If we, you know, take the big glute muscle, which is the biggest one of the fewer ones that are below that glute muscle is the piriformis, and it allows your hip to rotate. So sometimes that can kind of get that sciatic nerve kind of caught and or just cause some just general weakness to that hip area. So when it comes to sciatica, there's a few things that we'll do. Again, we'll spend a lot of time talking about pain management. We like to do a lot of hands-on work. And so we'll do a lot of work to the spine by trying to get the spine to move better. We'll do a lot of just passive stretching to get people moving. And then we do a lot of just soft tissue work. Sometimes that pain can be coming, but also have a lot of restriction in the hip and the back area. So we'll do a lot of work to try and get the area strong, looser just from using our hands with our manual treatments. We do, again, we're working on some strength training, and you can see that young lady's doing a nice little plank. She's got some great positioning there. We generally will have people work into this. This is a fantastic exercise for core stability, but it's also a really hard exercise. So we usually start people in a little bit of an easier position, but that's what a full plank might look like. And then the picture at the top just shows someone in a traction table. This is our traction table that we have in our office. And what we find sometimes is if the sciatica is coming from some compression in the spine, by using the traction, we can take those segments that are on top of each other that are compressing, and we create some distraction. So we get that distraction sensation. People really enjoy traction. It takes a lot of pressure off their back. It unweights their back. And so with that, I always tend to get a lot of questions about inversion tables. I'm sure everyone who has been up past the hour of 2 in the morning has seen the Teeter commercial with the guy who just hops right on and flips over and does, you know, twists and turns on that inversion table. And they all want to know if it's a good thing or not. So basically, my general premise is this. I always say if you are less than the age of 35, and you have maybe a very heavy-duty, labor-intensive job, that an inversion table could be a nice thing to have at your house to use on an occasional basis. Where I get concerned is when people maybe have some other medical issues that may affect being inverted. If you think of an inversion table, I'll have a picture of it, but you can see how the gentleman's laying flat. But imagine him just going from here and his head being where my elbow is and his feet where my fingers are. And so they're using gravity to get some just general pulling on the spine. So if you get dizzy or are on medications that can maybe cause some dizziness, or you have some issues related to general health issues, I don't think inversion is a good idea. So as you get older, usually I'm less inclined to encourage someone to try an inversion table, mostly just because of the potential other side effects that it can cause. But young and healthy, I think it's a great way to do some consistent unweighting of the lower back, which is a big cause of the sciatica when it comes from the spine. The third area that we work with a lot is the sacroiliac joint. We call it the SI joint. You may hear us call it that in the clinic. You can see from the picture, the SI joint is where the sacrum, which is the lower V-shaped bone, meets the ilium, which is part of the pelvis, or the sacroiliac joint. And you can see above the sacrum is the lower spine, the lumbar spine, with the discs in the middle. So sacroiliac joint pain generally is with people in their younger years, 20 to 30 years or so. Again, more female than male. A lot of women tend to have SI joint problems after childbirth, believe it or not, because of all the relaxing type activities that go on in the body for the body to accept the baby when it's getting into the right position. there's a lot of mobility issues that can occur, and they have a lot more weakness issues that can occur, which can lead to instability and pain. More often than not, SI joint pain is lower back, but a lot of buttocks. So it's kind of pain right in between the two areas. There's usually a lot of pain with sit to stand. And there generally isn't a lot of pain in the leg, which we see with the sciatica. So here's our third exercise, which we're going to talk about tonight, which is the posterior pelvic tilt. So with our patients with that sciatica issues, one of the things that we find, with the SI joint issues, is they usually have a lot of mobility. They move too much. So we want to try and get them to be nice and stable as we possibly can. So we work on making sure that they learn how to start engaging their core and get their core muscles really strong. So there's a lot of you out there that have really, when I say the core, you go, I know where the core is, but you don't really know what the core is because you haven't really used those muscles in a long, long time. And so for me, we spend a lot of time talking about how do we engage the core, and I'm just going to have you, I'll play this video.
Lying on your back with your knees bent and feet resting on the floor. Slowly bend your low back and tilt your pelvis backward into the floor. Then return to the starting position and repeat. Make sure to only move your pelvis and low back and keep the rest of your body relaxed.
So you can see there's not a lot of going on here, but just that subtle movement can be a really great game changer when it comes to pain. I'm going to show you one thing in a minute, and we'll talk a little bit about this. And again, don't forget, I'm going to send you these pictures. The nice thing about our program that we have is it has a video component to it. So the instructions and the pictures are great, but if you're still not sure, you go to a website, plop in a little access code, and there's a great video that you just saw. You'll be able to see that on your own through your computer. So it's a nice way to do that. So when we treat sacroiliac or SI joint pain, we're talking about pain management again. We're talking about breathing again. We're talking about postural corrective exercises. We're talking about stability training. So here's the picture at the top. So a clam exercise, very common SI joint exercise to get the hips stronger. And then we do a lot of activities to try to avoid. And a big one is crossing the legs. And crossing the legs can lead to some restriction in certain areas, some tightness in certain areas, some weakness in others. So we just try to encourage less leg crossing. So with those three problems in the lower back in mind, we're going to move to start talking a little bit about posture. There are some good ones, some bad ones, and some ugly ones. We'll talk a little bit about that. I think there's some of you out there that are still working, and we'll talk about some work postures. We'll get a ton of questions about sitting and standing tables. And then my mom is, I think, on the call. So hi, Ma and Dad, if you're there. And you know what, Mom is right. Getting yourself shoulders back and up straight is very important. So this is a variety of some different postures that we will generally see in the clinic. I will tell you that the middle three is really what we see the most. And there's the sway back one. We don't see too many people coming in the clinic with that. And I'm hoping that we see more people leaving with the last one in good posture, but generally we'll see the people in the middle. Most of us have a little bit of an increased sway in our lower back, in the lumbar lordosis. We all are rounded in the shoulders and the thoracic kyphosis. And then we have the forward head too as well. So those three, we see a ton of those all the time. And we're constantly working on trying to get those ones with the three in the middle to the one that's on the right. So that the lordosis is where a lot of our work comes from. So you can see the young lady in the bathing suit by the pool has way too much of a lordosis. And the gentleman without the shirt on the right, he again has way too much lordosis. So the young girl in the lower picture is just way too flexible. So we really want to talk to her about trying to get her core muscles engaged more. The guy without the shirt on has drank too much Budweiser and had too many chicken wings. And so he's just has gravity is affecting his abdominals. And so his lower spine is too curved and putting a lot of pressure on his lower back. Now, the young lady in the middle picture, you can see she doesn't have an excessive curve. Hers is kind of pretty straight and flat. And that's not good too as well. So we want to find that happy medium of not having too much curve and not having any curve at all. And so when we talk about thinking about trying to get the abdominals more engaged, we talk a lot about drawing in. And so what I say to people is, think about the last time you had to put a tight pair of jeans on. When they're tight, you have to really pull in your stomach muscles to buckle your pants in the front. And that's kind of similar to how we describe people to encourage them to try and learn how to start engaging their core. So that posterior pelvic tilt exercise, if you do it correctly, with that light tilting, it automatically makes you keep your stomach nice and tight. And so I encourage almost all of my clients to, once they learn how to do that, I ask them, you know, you're getting in the car, engage your core. Getting out of bed, engage your core. On and off the toilet, engage your core. Carrying the groceries in the house, carrying the laundry from the second floor to the first floor. Engage your core and draw in as best you can. Great way to start getting you thinking about getting that area nice and more engaged versus just kind of not really doing much of anything at all, which honestly with a lot of you, it's probably not doing much of anything at all. So sitting, as they say now, is the new, it's the new smoking, so almost all of us now that are working, and even a lot of us that are not working, spend a ton of time on the computer. And so all that time on the computer is creating just bad postures, which create tightness issues and or weakness issues. So I want my people that are using computers a lot during the day to get up and move around as frequently as they can. I'll have them set reminders or timers on their computer. I'll ask them sometimes, I'll have them take their computer and put a little sticker on the top corner of the computer, maybe a new picture or a little sticker or something. And every time they see that picture in the corner of the screen, it's their cue to go, you know what, I've got to sit up taller. I've got to get out of my chair. I just got to do something to get myself moving so I'm not stuck in that chair too long. Excuse me. So you'll see in the top picture, the lady on the right is who probably shows up at 7:30, 8 o'clock to the office. That's her posture. The one on the left is her about maybe 2:30, 3, 4 o'clock. She's tired. Her eyes are sore. She's just fatigued as the day goes along. She's got reports she's got to finish, but she wants to get the heck out of the office. And that's where things happen. So we need to get people more into the right-sided posture where she's got good support from the chair, good support with her arms, and instead you can see she's spending more time forward bent. Down below is just a little schematic of what's a really good position to be sitting in like. And you can see he's got good back support from the chair, screen is at eye level, arms are supported, back of the legs are supported, feet are flat on the ground. And then, we encourage a lot of standing and or sitting and standing. So at my 3 office areas in my clinic, we use what's called the Flexi Spot high-low table. So it basically sits right on top of our desk, and then with an easy lever on either side, the Allie and Kim, my office help, are able to just raise the table up so they can stand for periods and work in standing. But then if they get tired and they want to sit down, they can lower the desk back down. But the nice thing is just allows for some variability in the height of the table. It's really great things to have. Nowadays, the prices of them have come down, so you can get a really good one for about $200 to $300. And so I know a lot of you that are working with the COVID-19 issues going on, a lot of you are working from home. My son, Shane, who lives in Hoboken, New Jersey, is home with us because he's working from home. And I did a video about a month ago of his workstation, which we rigged up. We had boxes and things to kind of allow him to change spots. But a lot of people don't have those great ergonomic products that they had at the office when they're at their kitchen table. So I'll say to them, listen, think about making an investment into one of these devices, or just every 30 minutes, I want you up, walk around the table a couple of times, do some jumping jacks, do something, bend and touch your toes, do something just to break up the day and you're not sitting for too long. So, so basically what it really comes down to is it a stiffness problem? Is it a tightness problem? Is it weakness? Am I unstable? Am I stable? There's so many different things that we need to try and figure out when we work with our patients to determine what's going on. So usually they fall into two categories. One is what we call hypomobile, and that's the person who is too tight. They don't move well, they don't breathe well, their abdominal muscles are super weak, their lower back is super weak. And then we have more of a younger population. They may be moving too much. They tend to be loose jointed. They're like the young girl by the pool area that had that really big sway in her back. We want them moving less and getting stronger or more. That's an area. So it's, are you tight or are you loose? It's kind of how my brain thinks when I'm looking at someone with lower back pain. And then, we'll do a lot of stretching at home, with our clients here. But sometimes people come in and they just have way too much motion. But more often than not, what we see is people are tight. I think most of the people on the call, maybe other than Allie, have more than 50 candles on the cake, right? So for us that are older, we sit too much, we're a little bit not quite as active, we have a tendency to get more tight. And so I want those people stretching. We usually start off with what we call passive stretching. You can see the picture in the middle of the guy with the red shirt. He's doing that single knee to chest exercise, right? We talked about that earlier. So he's passively stretching his hip. But we can also have some people do some more active work, like the young lady who's on that white tube. It's a foam roller, and she's going to roll on her back to help her back loosen up. The guy looks like he's got an egg at his back. It's actually it's a hard lacrosse ball. And he's just going to roll his back on that just to kind of help loosen his back up. And you can see the lady down the bottom that's got the massage stick, and she's just going to try and work on her back by using that massage stick. So the nice thing is there's a lot of ways to kind of, to get yourself moving better. And we like to try and encourage people to do that. So we show them a lot of different ways. But finally, people say, I'm going to walk. Should I stretch before? Should I stretch after? What should I do? The research right now is not saying one way more than the other, to be honest with you. It's kind of really what I say to people is do what feels right, do what feels good. So I'll say, one time stretch before and then come back and see how you feel. And then the next time, why don't you go walk and then stretch afterwards and see how you feel. And you may have one that tends to feel a little bit better than the other, and I would go with that one. So it really goes down to being about the core. And you can see from the picture here, we've got 4 different muscles that make up the front part of our abdominal area. For us, it's not just the front though. We think about the core being the front that you see here in the picture, but also the back and also the hips. And that's what that whole entire area make up the core. So you can see in the back, there are muscles that attach on the picture on the left, this multifidus and quadratus lumborum. Those are 2 strong back extensor muscles that help to make the spine more stable. Then you see the picture on the right, which shows a lot of the muscles of the buttocks. So on the left side of the right picture, you see the big glute muscles. And then on the right side of the right picture, you can see when they take the glute muscles away, all those smaller hip rotating muscles that turn the hip inward and turn the hip outward that play a really important role in stability. So it's really just not about the stomach. It's all about the whole entire area, stomach, back, hips. So let's take a little bit of a break talking about the anatomy, and let's talk about chronic pain, because we see this a lot in the clinic. And I feel that pain management has a little bit of a psychology behind it. And there's a lot of new research out there that talks about how do you manage your pain? There's ways to manage pain. And think of it like this. A lot of us I love to do yard work. I'm out in the yard all the time. And you're out doing some yard work and you're doing something and you get like pricked by a rose bush, right? And you may feel it, but then you may not even notice it. And then you walk away and a couple minutes later you look down and your leg is bleeding because you get poked by the rose bush, but you never felt it. So how does that happen? How did something stimulus happen and you never even noticed it? But another time where someone did something to you or you had some response and you felt pain. So how does one time you don't even know what's going on, and then another time you saw it and you felt it, that it happens differently? And to me, I think it's all about how does the body respond to pain and how do you respond? You know, the body is constantly trying to protect itself. The brain's job is to protect the body from any pain. We all have heard about the flight or fight mechanisms in the body. And so the body was mostly built to just kind of go at a normal symbiotic level, nice and slow and steady. But at any point in time, it needed to be able to react quickly to move away from something bad. And so I use the thought of you're in the kitchen and you go to put your hand on the stove and you don't realize the stove is hot. Your body and brain will not allow you to keep your hand on that stove. You immediately respond by, oh, that's hot. I got to take my hand quickly away from it. And so this is the response that a lot of people end up having when it comes to low back pain. They do something, they lift something improperly, and they go, oh, and they end up kind of guarding, and they get into this situation where they end up, because of muscle tension and their response, they end up doubling their pain. And so one of the things that we talk a lot about right away is we say, listen, pain is normal. Pain is normal. And it's all about how do you decide you're going to respond to pain when it comes on. We use the scale of 10 in our office to help us judge it with patients. And I'll say to everyone, 0 to 3, don't worry about it. 4 to 6 on the scale, we'll be a little concerned. More than 7, now we're concerned. So most things happen in that 0 to 3 level. That pricker from the rose bush probably was a 0 to 3. The hammer smashing into your thumb is more like a 6 or a 7. So depending upon your response to that is going to lead to how do you recover. So we spend a lot of time talking about getting people to try and relax when their pain is coming on. And we do that by talking about some breathing. We'll talk about that in the next slide. And then the last thing I want to talk about is what I call tweaky things. And we get this happen all the time. People will come in, they're in the middle of their care and we're treating them and doing great. And then all of a sudden they go, I had this shooting pain down my leg and it like lasted for like 30 seconds. And then it went away. What do you think that is? And I'll look at them in the face. I'll go, you know what? I think that's the tweaky thing. And they look at me like, well, what are you talking about? And so a tweaky thing is, I don't know what caused that to happen. I'm not really sure. But I really only care about if it's consistent. So if it comes on and goes away, we disregard it. We just forget about it. 0 to 3, it came on, it left, move on. If it becomes more consistent, happening more frequently, intensity is increasing, things like that, now we're a little bit more concerned and we'll look at it a little bit further. But a tweaky thing, we just kind of push that off to the side. And this is something we see a lot with our chronic pain patients. They get caught in this chronic pain circle. They start off with they're having an increase in the amount of pain. And with that, they have worries about their job, general worries about their health, worries about their family. They get anxious about that. They don't sleep well. they end up having trouble with rest, and they can't get out of their own way. Now, all of a sudden, they have to go to the doctor, they have to pay bills, and they don't cope well with that increase in pain, which just keeps them in the cycle. So our job is to try and teach you guys how to get out of the cycle of pain by using things like breathing and stretching and engaging your core to allow you to learn how to work your body to its greatest benefit. And so we talk a lot about breathing from the diaphragm. And you can see from the picture on the left, the diaphragm separates our lungs from our abdominal cavity, and it looks like a parachute. And so as we breathe in and we breathe out, the diaphragm has to move somewhat up and down. But a lot of times when we breathe, we think about our chest breathing and we breathe this way forward. And what I ask my patients to think about is, can they breathe in and out, but think about breathing down? So their lungs inflate, they push down into the diaphragm, which actually is the roof of the core. And so, believe it or not, diaphragm's a muscle. So we can get the diaphragm moving well. It's going to help us engage a lot of the other muscles around that area. So if we can get that going and get those muscles more engaged, number one, it allows people to calm themselves down. They start to breathe and sit quietly in a very comfortable position. Two, it starts to automatically allow them to start to engage the diaphragm and the core muscles. And then three, hopefully it's going to allow them just to start having some better pain management skills. So I'll ask people that when they have an increase in their symptoms, they're going to find a comfortable chair or the couch or the bed, sit quietly for 2 minutes, put one hand on the stomach and one hand on the chest, breathe in through the nose and out through the nose. And as they breathe in through the nose, try to get the stomach to expand. And as they breathe out through the nose, get the stomach to fall. And try to spend some time, just maybe 3 to 5 minutes tops, of just relaxation and breathing. And it's amazing what that little bit of work can do in helping calming down your pain levels. So here's some goals for people that I think are really super important. I find that most of our clients, a lot of them are over the age of 50 candles when it comes to low back pain. And so we want them moving. So we want them stretching, almost daily. We want them getting out and doing some walking, some aerobic conditioning, maybe walking, riding a bike, swimming laps. We also want them working on some resistance training to build strength. So working with exercise balls or bands or weights. If you've been into our clinic, you know that these are the three kind of pillars of our ideals when it comes to doing exercise and the goals that we set for most of you that are getting some treatment. So this is the point where I say to you, what are you going to do about this? There's pretty much three things. One, you can ignore it. Two, you can try to alter or change it. Or three, you can try to handle it. And I use this story in my workshops. And for those of you who've heard it before, I apologize for repeating myself, but I think it's perfect. I have a gentleman who I consider a mentor in physical therapy. He has clinics down in Pennsylvania, and in one of his buildings, he was in the middle office of a 5-suite building. And he kept getting this one ceiling tile that would get stained. He'd have a heavy rain. He knew the next day the ceiling tile would stain. So, he didn't do anything about it. He completely just ignored it to start with. But then he would have his staff going, geez, what's wrong with the roof? Or it looks awful. Can we change that out? Some of the patients complaining it looks like it's going to fall on them. So he said, you know what? I'm going to try and change it. So what did he do? He went to Home Depot and he bought a stack of ceiling tiles, just replaced the ceiling tile. Well, every time it would rain, it would stain again. And he thought, you know what? I got to probably try to do something else instead. So he reached out and he called the HVAC guy. And so what did he say? Those of you that owned houses, what does he say? It's not me, it's the roofing guy. And so he calls the roofing guy and the roofing guy says, it's not me, it's the HVAC guy. So now he's going, now what the heck do I do now? I don't even know what I'm going to do. And so now all of a sudden he's talking to somebody. He says, listen, I want you to call this guy. He's great. He'll help you out. And this guy who was a roofing guy, came to his building and checked it all out. And he said, you know what, it's not your space. It's the suite 3 down, 3 buildings down. That's where the leak is coming from. The water is coming in from the side of the building. It's running down through one of the joists. It just happens to be stopping here, and that ceiling tile is wet because of it. So it took him a while, but he decided to handle the problem the right way, which was find the right guy to do the right job and then get that person to help him fix the leak, which he did. And now he's got all these extra ceiling tiles that he doesn't know what to do with. So, but he has a roof that's not leaking, which is the most important thing. So most of you may need to get a referral to see, to come see us, which is fine. And you get that by going to your doctor. So what might happen then? So for me, my hope is that you're going to get a clinical exam from the doctor. We have great relationships with a lot of the local primary cares, and a lot of them would just say, go to physical therapy. Just go get physical therapy. And if it's not with my clinic, it's hopefully at a lot of the other really good clinics in the area, and you get your favorite physical therapist to work with you in fixing this problem. And again, we talked about it. They will not give you an MRI unless you've had 6 weeks of pain in the leg. That's usually when they'll start talking about MRI. Nowadays, they will not give you pain medication, which is fantastic. That's what I want to have happen. What I'm always concerned about, though, is I don't want them to say, don't worry, your back pain will go away. And to that, I say to you, how has that worked for you so far? Because if you've had back pain for a long time and you've done nothing to fix it, you will always have back pain. So until you make that decision to do something about it, my encouragement to you is don't think it's just going to go away on its own. It will not. It will always be there. So for us, if you come to our clinic, what we do is we spend an hour with you off the bat. We want to know what are your problems? What are your medical health issues? What do you want to do? What can't you do? And we help you figure out a plan to make that happen. So that way you can hopefully get going in the right direction, start feeling better, and getting back to the things that you want to do. And again, we've talked about this in some of the other slides. We do a lot of work with posture. We do a lot of work with strength and endurance. We do a lot of work with balance too as well. And so Allie mentioned it earlier in the presentation. We do have 2 options for care. One is a free lower back screen. So this is where you would call our office. It's a 30-minute appointment. You'd meet with one of my physical therapists. We would take some basic information from you, do some basic movement patterns, and determine a couple of things. One, do you maybe just need some home exercises? And that's all you need, and work on those at home. 2, maybe you need some home exercises and some treatment and physical therapy. Or 3, you know what? You need to see a doctor. And we're going to help you figure out if it's one of those 3 situations. And so if you decide to do a regular evaluation, that's evaluation is for an hour, and we spend a lot of time. I think I said the screen is 30 minutes. The evaluation is for 1 hour. And we with the evaluation, we're taking your insurance information. We're trying to get coverage through them. And we, again, do a full evaluation. You leave there with some exercises and a plan to do certain things moving forward. Now, I will say right now, we have been open during the COVID-19 crisis, but now we've been extremely super busy. The past month, we're getting busier and busier. People are getting out of the offices. Our physicians that we work with all the time are now back seeing patients and doing surgeries. And so now we're actually at the point of getting really super busy. So if you're interested in either a screen or an evaluation, I just ask that you be patient. You can start working on those 3 exercises I gave you to do, and bear with us as we will do our best to try and get you in the clinic probably sometime in the beginning of July, if not the middle of July. So just bear with us as we get going. But I would applaud every one of you that decide to handle this and try to start working on doing something to change your pain levels. So that is all I have to say. I'm going to, Allie, if you're still there.
All right, so Kevin, that was a great presentation. Thank you so much for that. I definitely learned a lot about my lower back pain tonight, and I hope you guys did too. At this point, we're going to open up the question and answer section of the presentation. And to go ahead and put any questions or comments, you can just go ahead and type that into the chat box for me, and I will go ahead and let Kevin know that it's ready. So go ahead and do that now for me, okay?
Allie, do we have any questions yet in the chat box or?
I don't see anything yet, Kevin.
Okay. Well, we'll stay on the call for a little bit. Because I have the presentation open, can't see the chat box, but Allie can see it. So if you have a question, feel free to throw it out there. If you don't have a question, not a problem. I'm glad that you all could make it tonight. It's really exciting for me to be able to start doing these. We're used to doing these in the clinic, and it's great that we can still be doing these for you all that aren't comfortable coming out of the house. And our next few that we have coming up will be virtual. Our next virtual workshop is going to be about neck pain. So that's going to be on Thursday, July 30th, which will be from 6 to 7. So, so we hope that you're able to come to that. If and again, it will be virtual. We'll do the same thing like we did. We'll send you a Zoom link, so that way you can get in and hear that, and then and that's about all I have to say about that.
All right, Kevin, I have a question from Michelle.
Sure.
I want to know if she can do the exercises regardless of what her lower back pain may be from.
The reason why I chose those 3 exercises is because almost everyone that I see with lower back pain, that's what you start with. There's 6 exercises I start with. These are the 3 main ones. So my encouragement to you would be to start with them, but to realize that if you go at them very aggressively, they're going to make your back pain worse. So just go slowly. Don't be trying to overstretch or strain anything. And the intent is to really work on trying to create some movement, but not at the expense of pain.
All right. Linda also said thank you very much, but other than that, there has been no other questions.
Awesome. All right. Well, I want to thank everyone for being on the call, and have a great night, and hopefully we'll see you all soon. Thanks so much. And Allie, thanks so much.
All right. Have a good night, everybody. Thanks for joining.